I'm Stefan Voo. I'm a nuclear medicine physician at the University College London Hospital. My main focus is molecular radionuclide therapies. So it is a pleasure to be here and present our evolving experience with PSMA theranostics. So we've heard already quite a lot about PSMA. So every nuclear medicine meeting is about PSMA and the evolving implications of PSMA PET, but also about PSMA therapies. So we are all using small molecules, radiolabeled either with gallium or F18, as you have heard, and it's used for imaging side of things, and it's part of the theranostics. However, today I would like to focus more on the therapy side. So the small molecule in this case is labeled with a beta emitter, in this case lutetium-177, which has a 1 millimeter path length and 7-day half-life. Now with this 1 millimeter path length, we effectively target the tumor cells, but also the neighboring tumor cells, which might be less expressing PSMA or even PSMA negative. So by doing that, we practically kind of limit the effects of tumor heterogeneity. But with a shorter path length, it also means that practically we do not damage or less damage to the normal tissues. My first interest in therapies, but particularly for PSMA therapy, was sparked by research done in Heidelberg with MIP1095, a small molecule originally labeled with radioactive iodine, as showing exceptional response. And then also in 2015, this research from Richard Baum in Bad Berka using lutetium-177 INT, which is a different molecule, still used today quite widely in the clinical setting. But the molecule which has really entered commercially, developed in this was developed commercially, is in this PSMA 617 in the initial case report from the Heidelberg group in Germany, showing a complete response on PSMA PET to 2 cycles of therapy back in 2015. Of course, VISION trial. I think VISION trial is one of the most elegant trials in nuclear medicine we haven't designed. And the VISION trial focused practically on lutetium PSMA therapy, testing it in metastatic castration-resistant prostate cancer patients who exhausted all other therapeutic options. This was an international open-label phase 3 trial, as I said, where the patients were included, were treated with both modern androgen, one-line androgen receptor pathway inhibitor, 1-to-taxane regimens. The patient had relatively good performance status, but please keep in mind that these patients are terminal patients who exhausted all other therapeutic options. The patients were randomized to standard of care treatment, so practically no treatment anymore, functioning, and on the treatment arm, standard of care plus lutetium-177 PSMA. And these are the first results published in New England Journal of Medicine by Sartor, and practically what they have seen that there is imaging response progression-free survival, and an overall survival was much better compared in the treated arm compared to the control arm. So practically we have a gain in overall survival from 3.4 months to 8.7 months. Again, these are terminal patients who exhausted all other therapeutic options. Now, this is absolutely fantastic, considering also that the treatment is associated with relatively poor side effects. Poor when I'm saying no side effects, or very minimal side effects compared to all the chemotherapeutical possible. So bone marrow suppression, again, it was more pronounced indeed in the treated arm compared to the untreated arm, but again, these patients have exhausted and they have been heavily treated, so the bone marrow reserve to start with was not perfect. Dry mouth occurred in about 39 to 40%, so this is one of the side effects of the treatment, and nausea and vomiting on the other side. But as you can see, all of these side effects had a grade 1 or 2 compared to 3 to 5. So based on this vision trial, we were very enthusiastic, 2018, 2019, 2020. So in 2021, Prostate Cancer UK really highlighted on the website that kind of a new therapy is coming. Can a drug act like a guided missile to target advanced prostate cancer? And the president at the time of the Prostate Cancer UK says this is a big win for the prostate cancer, and the prostate cancer charity will be working closely with NHS and pharmaceutical companies to make sure this happens. We should be proud because in 2022, UK was the first country in the UK to clear lutetium-177 PSMA 617 for treatment for prostate cancer patients. So practically the UK regulators have become the first one in Europe to approve this treatment for patient treatment. So this was fantastic news. So, of course, at UCLH, we have quite a lot of a long history of doing theranostics, so we immediately adopted the idea and started treating patients on compassionate value, and also based on the early EAMS, early access to medicine schemes. So we were one of the first sites to do this in patients, and we treated at that time 32 patients. These were patients who were not very well. Most of these patients, 80 to 90%, have been already treated with abiraterone and enzalutamide or both. 48% have been already treated and were progressing on cabazitaxel. So practically all these patients had no other options. So we put together the data. We submitted also to the stakeholders, and practically this shows the updated, the waterfall plot of the PSA decline presented also at the BNMS in 2023. We saw a decline of 50% in PSA value in about 64% of the patients, so a fantastic result. Compared to 2 patients which have progressed on treatment, I also want to highlight that there were also cases where the patients dropped the PSA levels to almost 0. So practically we had very good complete metabolic response on follow-up PSMA PET, which is quite remarkable for this group of patients. So practically these are the very good responders presented also by the group of Hoffman as SNMMI further. Of course, we wanted in 2023 we were waiting for the answer from NICE, and we expected positive results or a positive answer at that time. And they have done a very intricate analysis of the vision data and other data submitted by the company. And of course, it came in the balance between the benefit and the costs. On one side, they said, yes, that's very nice. There is an unmet need for new treatments for PSMA-positive hormone-relapsed metastatic prostate cancer. Lutetium-177 PSMA is positioned appropriately in the treatment pathway. The vision trial is generalizable to clinical practice in the NHS. However, the eligibility is determined by PSMA imaging, and remember at that time, PSMA imaging was not really paid by NHS England, so they said access to this imaging is limited and not a standard practice across the NHS. Second, lutetium-177 is clinically effective compared with standard of care, but there is a high withdrawal rate from vision. Which means that the effect size is uncertain. Well, we treated terminal patients, so that's not a big surprise in my idea. But the most important part was the cost-effectiveness estimate for lutetium-177 PSMA are uncertain, but suggest that it is not cost-effective. Therefore, in 2023, it was a reflection moment. I call this diplomatically because it's kind of a chaos moment. What to do further for PSMA RLT provision in the UK. And we had to look back to our national audit. to look like health system readiness for radioligand therapy in the UK, which highlighted there are massive gaps in provision of RLTs across the country. You have geographical inequalities offering this type of therapies in many centers. Of course, there is a lack of consistency in the protocols and the therapy protocol at that time. Of course, it's not paid, etc., etc. So, how are we now? Well, slightly better, and I'm proud to say that there is further progress in the provision of PSMA theranostics in the UK. Why I'm saying that? Because early this year, in February 2025, finally NHS England said the commissioning, released a commissioning policy saying prostate-specific membrane antigen, as my colleague has presented, in positron emission tomography, computed tomography imaging for individuals with high-risk primary and recurrent prostate cancer patients is paid now, and it's part of standard of care, hopefully in many centers across the country. Second, with regard to therapy, of course, industry facilitated our whole training program, and UCLH, I'm very proud to have been proud of the national training, to be selected as a national training site for providing PSMA radionuclide therapy. So we had guests, various healthcare professionals visiting our site and doing together with us the therapies. 50 new sites aiming to open this kind of service in their sites. Of course, this helped also for RSAC licensing for many healthcare professionals and opening of new RLT services centers across UK. Further, we go to practical aspects of PSMA radionuclide therapies, guidelines. We have had, proudly we created in 2022 with Sabina, the PET guidelines in the UK. And I had to look back now, what's the evidence-based, in instance, for PSMA radioligand therapies? Well, there are already many guidelines. European journal ENM and SNMMI came out in 2023 with procedural guidelines. Very nice. In the same year, a small group also from SNMMI came up with their guidelines on patient selection and appropriate use of lutetium PSMA radionuclide therapies. As you can see it in this one here. Of course, in the same time, American Society of Clinical Oncology came up with their guidelines on the provision of lutetium PSMA therapies. And of course, you have already 3-4 guidelines. So, okay, there are some similar parts in these guidelines, but there are also discrepancies between them, which explains why big groups in the United States providing PSMA therapies came up with their own recommendation. So, in other words, do we have consistent guidelines at the point? No. So I really hope, with Sabina's help, that we will have this year, at the end of this year, new guidance in UK concerning the provision of PSMA therapies. Of course, we look how to build up established, robust radioligand therapy. And this is a very busy slide. It reflects a little bit how in the United States the provision of radionuclide therapy is being built up. But you see how many stakeholders and how many important components have to work together. And then you have big centers which should be jointly working with smaller centers providing a state-of-the-art radionuclide therapy and provision of this service. This is how it should work. Well, it doesn't apply, in my opinion, only to the United States. I think it applies also to the UK. So practically, first of all, before you start a radioligand therapy, what is the minimum caseload? How many patients you have in your center to treat? Of course, if there are only few, it's not financially feasible to start building up your own service. You better work in collaboration with another center. Of course, radioactive material licenses, authorized users, radiation safety program and radiation safety officers, nursing staff, technologists, medical physicists, pharmacy are important elements for every single radionuclide therapy service if you want to have a robust one. Of course, Another important component, and what I learned at UCLH, is practically oncologists having them as equal partners in offering this therapy. It wouldn't work if I would say these are my patients and I'm treating them as nuclear medicine physician. No, it's 50-50 joint collaboration with uro-oncologists and also with other providers with whom you can partner. Having more collaborators will offer you a better and a more robust system. And of course, then it comes the physical part, that dedicated space and the treatment setup, but I won't get into details with regard to that aspect. Patient selection, that's very important because we already started having centers in the UK who treat kind of differently, select patients differently than other centers. Well, patients with metastatic castration-resistant prostate cancer patients who have been treated with at least one line of androgen receptor pathway inhibitor, this is the clinical indication which kind of in every single guideline is mentioned. Of course, relative contraindications, myelosuppression, low GFR, urinary obstruction are considered relative contraindications in some of the guidelines, not on the other one. So the question is whether we should really interrogate these points when we select the patients, doing GFR for every single patient and MAC3s. I'm just saying it. PSMA positivity is defined, as my colleague has said, PSMA uptake should be higher than the liver. And of course, if you look at the promise, they say, well, the parotid glands, they have a higher background expression of PSMA than the liver, so let's take them also into consideration, which makes the PROMIS V2 version 2 criteria, which you have 4 levels. Level 2, higher uptake than the liver, well below the parotid, and level 3, higher than the parotid. Both these level 2 and 3 would be indication for therapy. I wouldn't choose necessarily higher than the parotid. There is no such, there is no robust data to confirm that only those patients will respond better. However, if the uptake is higher than the parotid, you can tell the patient you have a higher chance to respond to the treatment. That's the only thing. So, is this patient suitable for therapy? It has PSMA avidity, SUV max 70. We don't have time to do a quiz now. We are not doing FDG case PET CTs in every single cases, only in selected ones. Now, this is a case from Hoffman in Australia. They have done a PET CT, and as you can see, well, there is FDG-avid disease, and most importantly, there are FDG-avid liver metastases, which were not PSMA-avid. So to make it even clearer, we color code, and in blue you have the sites of disease which you can treat with lutetium PSMA. In red you have the sites which are not PSMA-avid, so you will not treat, and these parts are actually the most aggressive sites, the dedifferentiated one. So if you give therapy in this kind of patients, which is all fine, it's a terminal patient, so we intend to help the patient. What happens, and there are cases already in the literature demonstrating that practically you treat the PSMA, you let the non-PSMA-avid disease, the FDG1 avid, to explode, being the dominant one. So are we helping the patient? We don't know yet. So that's why in the therapy a trial designed by by Hoffman group, practically they said that when you have discordance between FDG and PSMA, these patients maybe are unsuitable for therapy. Here you see the cases and highlighting the FDG-avid disease, PSMA-negative disease. Now, they haven't treated these patients in their cohort. They excluded them, although they had PSMA-avid sites. And practically what they have seen, that all these patients which they excluded, they had a very, very poor overall survival of 2.5 months. So practically you do the therapy for a patient who has less overall survival, less than 6 months, which is one of the criteria to do the whole therapy. Therapy procedure-wise, well, this is very simple. To avoid side effects, hydration is saint. So 30 minutes before the therapy, during the therapy, the patient has to be very well hydrated. You don't necessarily have to do IV hydration. If the patient is compliant, the patient can drink 1.5 to 2 liter of fluids per day, but that's very important. Supportive medication is not necessarily recommended. However, as you have seen in the VISION trial, 30 to 40% of patients will have nausea the days after the therapy. So practically giving them ondansetron, you will improve their quality of life. So we as nuclear medicine physicians, we should start also prescribing medicines. Second is corticosteroids. If you look at the 4 guidelines, they say, well, you can, it's a sort of coulda, woulda, shoulda. However, I think it should be mandatory to give corticosteroids for patients with brain and spine mets. So that's, I think, extremely important. So some of the groups give furosemide to the patients to help excretion and drop the toxicity to the kidney. There is no such evidence in the literature. However, what can happen, and physics will not be happy, the patient may have, because of the pelvic floor, they may have urinary contamination while walking towards the toilet. We got one. And it was absolutely not fun to clean it up. Therapy administration, there is no gold standard. You can do injection with a syringe, manual, a pump, or a gravitational method. At UCLH, we have chosen the simple one and the cheapest one, which works fantastically, the gravitation one. So you choose exactly what you would like to do. I think if in your case works very well, there is no such thing in the guidelines recommending one against the other. Post-therapy imaging, well, yes, let's do it because we want to demonstrate that the medicine goes where it should go. The guidelines say, please ask the patient to stay 4 hours and maybe come back 24 and 4 days after the therapy. Now, these are patients with mets. Coming back 3 times to do the imaging, I'm not very sure they will be very happy. And being in Zone 1 London, we have patients coming from far away. I can't bring them 3 times after therapy to UCLH just to scan them. So what we have chosen, the very simple way, remember we do theranostics. PSMA imaging, PSMA PET, you do it 1 hour after injection. You don't have to keep the patient necessarily 4 hours. What you want to see is it goes where it should be, in the mets. So practically, this is the pre-therapy PSMA PET-CT, a PSA level of 5,000, cycle 1, planar imaging 1 hour after injection, exactly like PSMA PET-CT, demonstrating nicely that the uptake in the bone metastases is present. After cycle 6, PSA was 35. It was almost undetectable sites of disease. Very good response for this patient. So planar imaging is enough. As I said, we do the therapy. We talk about overall survival, which is absolutely fantastic, but we treat patients for God's sake. So quality of life should be maintained. One of the toxicities is the salivary gland. So in 2024, we have published a sort of review on molecular radionuclide therapy-induced salivary gland toxicity, and we concluded that this is an unappreciated threat for a patient's quality of life. So practically, we should start interrogating the patient. We prepare now questionnaires for assessing when the patient before the therapy, whether they already have a preconditioned salivary gland problem. And of course, if they have the smallest toxicity, we do salivary gland scintigraphy and saliva flow test, which are very important. How do we protect the salivary gland? Well, in Germany, in instance, they will do the cooling, which is controversial. It's no clear benefit. But botulinic acid injections work fantastically, but this is very difficult to do in already a cancer patient with multiple metastases. So what we have done initially, we have done a sort of virgin mojitos, ice, water, lemon. The patient did not like it to cool it down, but they understood the fact that, well, we want to stimulate their salivary gland, and we got very minimal toxicities in our patients. How do we treat xerostomia? Do we know how to treat it? Well, we say, we send the patient to dentist, or we say, sorry, you need the therapy to save the cancer. Yeah, but this patient has 6 months to live with dry mouth, and no taste anymore. So artificial saliva is very important, and hopefully this year with new recommendations, we are trying to publish together with the oral medicine and dentistry at Eastman Clinic at UCLH how to treat salivary gland diseases. Further developments in PSMA therapies is very important if research clinical trials are coming to UK, and I'm very proud to say that UK accommodated many new clinical trials. Beyond Vision, we have been part of PSMA4, the Splash trial, and Stampede, in instance, PSMA addition, where we try to bring the therapy much earlier in the therapy setting, so not only the end-of-life treatment, but in patients to compare it with chemotherapy, but also in patients with hormone-sensitive prostate cancer. This is a first result of the PSMA4 trial, which you see that the treated arm has a much better overall survival, progression-free survival of 12 months compared to the 5 months in the control group. And this is the Stampede 2 trial, which runs at UCLH, where patients who are SABR eligible go for SABR. Ineligible, they will go for lutetium PSMA therapy. Hopefully, soon we'll get also the actinium, and I'm hinting towards the next speaker. There are already 2 trials recruiting, so we have treated 8 patients, 4 patients in, so 12 patients in both trials with actinium PSMA, 4 cycles, 5 cycles of actinium PSMA therapy, and end of this year, will ACT Resolute trial also in actinium will start at UCLH and in UK. So to conclude, radioligand therapies, including PSMA, is an emerging pillar in oncology care. It still needs to be recognized by many stakeholders and governing institutions. The implementation of more services across country is strongly recommended. We need procedural guidelines on PSMA RLT and managed how to manage the side effects, but new guidelines are in preparation. And there is hope that NICE at one point will approve PSMA RLT, probably in the near future. Thank you.